This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
On February 1st, 2015, the New England Patriots were playing the Seattle Seahawks in Super Bowl 49. Maggie and her husband Joe watched the first half of the game together. Right before halftime, Maggie went upstairs to do a few things in their bedroom. Joe heard a loud noise, but didn't think anything of it. He thought their kids were just messing around upstairs. Seattle scored, and Joe yelled upstairs to Maggie. Maggie didn't respond, so he went upstairs to check on her. To his surprise, he found Maggie lying on the bedroom floor on her back, unresponsive. He tried talking to her and touched her face a little bit, but no reaction. Eventually, he did get a response out of her, but it wasn't a verbal one. She just opened and closed her eyes and swatted his hand away as he gently touched her face. They didn't know it at the time, but Maggie had just had a tonic-clonic seizure, formerly known as a grand mal seizure. She'd never had a seizure before. Joe called 911, and Maggie was rushed to a nearby hospital. A brain scan was performed, and the doctor told Joe and Maggie that the scan was abnormal and that they were going to take her to a major hospital as they were better equipped to deal with her issue there. It turns out Maggie had a brain tumor that needed to be removed. On February 5th, just 4 days after her seizure episode, Maggie underwent brain surgery to remove the tumor, which was the size of a golf ball. A brain tumor is an abnormal growth of tissue that can interfere with normal brain functioning. There are approximately 120 different types of brain and central nervous system tumors. They occur most frequently in adulthood, with the average age being 57, and about 700,000 Americans are currently living with one. Maggie herself was 42 years old when doctors discovered her brain tumor. Tumors are typically characterized by their specific type and their grade. In other words, how aggressive they are. We can also identify them as being either primary, which means they start in the brain itself, or secondary, which means they start in another area of the body and are carried through the bloodstream to the brain. So in other words, the tumor metastasizes or spreads, which is typically the case with cancerous ones. Cancerous tumors grow rapidly, and they don't have clear borders, so they invade surrounding brain tissue. They can also easily spread throughout the brain and the spinal cord. Not all brain tumors are cancerous, though. Only about 32% are. Noncancerous tumors are labeled as benign. Benign tumors are the least aggressive type of tumor. They don't contain cancer cells, they grow rather slowly, and they originate from cells within or surrounding the brain. They also tend to have clear borders that do not spread into other brain tissue, and they can become quite large before any symptoms appear. Don't be fooled by the word benign, though, as even these tumors can cause significant brain abnormalities. If brain surgery is performed, and if the tumor can be entirely removed, it tends not to grow back. Maggie's tumor was benign. It grew slowly within her brain, and she only knew it was there because she had a seizure. Tumors are graded on a Roman numeral scale ranging from 1 to 4. Lower grade tumors, grades 1 and 2, are not very aggressive and are usually associated with long-term survival. Maggie's tumor was rated as a grade 1. The higher grade tumors, grades 3 and 4, grow more quickly, can cause more damage, and are often more difficult to treat. They are also malignant or cancerous. Although there are a wide variety of brain tumors, some occur more frequently than others. One type, glioma, arises from glial cells found in the supportive tissue of the brain. Two common subtypes include astrocytoma and oligodendroglioma. Astrocytomas can be any grade, so 1 through 4. These tumors begin forming in supportive tissue cells known as astrocytes, which is a type of glial cell. They occur most often in adults over the age of 30, and they account for about 40% of gliomas. In adults, they are primarily found in the cerebral hemispheres, where they can cause pressure, seizures, and personality changes. The grade 4 version of this tumor is called a glioblastoma. Oligodendrogliomas are typically grade 2 or grade 3 tumors. They also start in the supporting cells in the brain, and they represent about 4% of all primary tumors. They are found in the cerebral hemispheres and can cause seizures, headaches, weakness, sleepiness, or changes in behavior. A second type of tumor is called a meningioma and accounts for approximately 33% of all brain tumors in adults. This is a slow-growing benign tumor that comes from the outer coverings of the brain just underneath the skull, so the meninges. Because of its slow growth, this tumor may exist for many years before it's detected. Maggie had a meningioma on the left side of her brain near the wing of the sphenoid bone. This bone is located in the middle of the skull toward the front, so behind the eye. In the picture you see on screen, you can clearly make out Maggie's tumor in white on the left side of her brain. Keep in mind that on a brain X-ray, left and right are reversed. A third type of tumor is known as a schwannoma. This tumor is usually benign and arises from supporting nerve cells called vestibular schwannomas or acoustic neuromas. These slow-growing tumors can cause hearing loss, balance problems, and weakness on one side of the face. The last two common types of tumors are pituitary tumors and central nervous system or CNS lymphoma. Pituitary tumors can affect how the pituitary gland functions and can result in vision problems. They are frequently benign. CNS lymphoma is malignant and originates from lymphocytes found in the brain, spinal cord, or eyes. Regardless of the type of tumor a person has, some of the more common general symptoms they might exhibit include headaches, seizures, difficulty thinking, trouble speaking or finding words, personality changes, tingling or stiffness associated with one side of the body, loss of balance, vision changes, nausea, or disorientation. Symptoms will differ based on the location of the tumor, so let's examine the effects on each area in turn, starting with the 4 lobes of the brain. When a tumor develops in the frontal lobes, typical symptoms include planning and organization difficulties, personality changes, irritability, weakness in part of the face or on one side of the body, trouble walking, disinhibition, apathy, inability to smell, and vision or speech problems. When a tumor develops in the temporal lobes, symptoms can include the inability to remember words, short-term memory loss, and seizures accompanied by strange odors or sensations. In the parietal lobes, symptoms can include trouble with speaking or comprehension, difficulty reading or writing, and loss of sensation in areas of the body. A tumor in the occipital lobes can lead to vision difficulties or the loss of vision in one eye. Other common tumor locations besides the lobes of the brain include the cerebellum, brain stem, pituitary gland, and the meninges. A tumor in the cerebellum is associated with symptoms like uncontrolled eye movements, poor coordination, nausea and vomiting, dizziness, and stiffness of the neck. In the brainstem, a tumor can result in a drooping eyelid or mouth, poor coordination, trouble swallowing, speaking difficulties, or double vision. In the pituitary gland, a tumor can cause irregular or infrequent periods, infertility in both men and women, listlessness, mood swings, high blood pressure, diabetes, weight gain, and enlarged hands or feet. Finally, a tumor in the meninges can cause nausea and vomiting, vision problems, headaches, or neck pain. I asked Maggie whether she had noticed anything that wasn't quite right days or months before she had her seizure. She told me two things. One, she said she was having massive headaches that she attributed to stress and being overworked. And two, she was having auditory hallucinations. She said that sometimes it was almost as if she could hear a crowd at a distance, and it made her feel a bit disconnected from reality, like she was having an out-of-body experience. Turns out Maggie was having mini seizures and didn't know it. Once again, though, she thought that it was stress or that she was just overly fatigued. In hindsight, she wishes she had reported these symptoms to her doctors, as perhaps they could have detected the tumor before the tonic-clonic seizure occurred. Over the years, a number of potential risk factors for tumors have been proposed and examined. Unfortunately, many of these factors lack the evidence needed to make any causal associations. In most relevant studies, validity is often questionable, and scientists lack biological measures for assessing exposure to a particular risk factor. Consider air pollution, for example. How can we determine whether exposure to air pollution increases the likelihood of brain tumor development? To answer this question, we'd need to know what type of air pollution we are referring to, how long a person has been exposed to the contaminant over the course of their lifetime, what concentration level of the pollutant the person was exposed to, and what other characteristics the person had. So medical, genetic, and so on, that could increase their chances that exposure would result in the development of a brain tumor. So as you can see, it's complicated. This is why many theories have been proposed, like air pollution, exposure to pesticides, and so on, but very few currently have any strong scientific evidence to support them. Other factors that have been examined include genetic conditions, cell phone use, exposure to the nitrate oxide releasing compounds, NOC, and exposure to high-dose ionizing radiation. A few genetic conditions have also been associated with brain tumor development. These include Cowden syndrome, Gorlin syndrome, Li-Fraumeni syndrome, neurofibromatosis types 1 and 2, tuberous sclerosis complex, Turcot syndrome, and von Hippel-Lindau disease. These conditions are characterized by various types of tumor growths. For example, Cowden disease, a multi-system autosomal dominant disorder, is characterized by benign overgrowths which are associated with a lifetime risk of various cancers. As another example, Turcot syndrome is characterized by multiple benign growths in the colon that actually occur in association with a primary brain tumor. So these genetic conditions do increase one's risk. What about the use of cell phones? Does using a cell phone increase your risk of getting a brain tumor? We know that using a cell phone exposes us to radio frequency electromagnetic waves, but does this exposure result in tumor development? At least 9 meta-analysis studies have been published on this issue, and the results are, surprise, inconsistent. Some have suggested that there may be an association between risk of tumor development and long-time mobile phone use, so more than 10 years. There were many limitations to these studies, though, and the general conclusion is that we currently have no strong or consistent evidence linking cell phone use to brain tumor development. What about exposure to NOCs, the nitrate oxide releasing compounds? You're exposed to these compounds when you consume things like red meat, processed meat, bacon, and hot dogs. Does consuming these products increase your risk of developing a brain tumor? According to the 2 large cohort studies conducted in 2009 and 2010, there is currently little evidence to support this hypothesis. Finally, what about exposure to high-dose ionizing radiation? This actually turns out to be the only suggested risk factor with a lot of supporting evidence behind it. Scientific research shows that this is a risk factor, especially for gliomas, meningiomas, and something called nerve sheath tumors. A nerve sheath is a layer of myelin and connective tissue that insulates the nerves that branch out from the brain and spinal cord. So a nerve sheath tumor is an abnormal growth within the cells of this covering. Exposure to high-dose ionizing radiation is especially prevalent in patients who underwent brain high-dose radiotherapy for cancer treatment in childhood. In sum, the risk factors for brain tumors remain largely unknown. Most likely a number of factors, environment, genes, lifestyle, age, and so on, play a role in determining whether or not an individual will develop a brain tumor. When it comes to treatment options, it's highly recommended that a multidisciplinary team be put into place to treat a brain tumor, including medical oncology, radiation oncology, and neurosurgery. Treatment decisions should be based on the tumor type, malignancy potential, tumor location, and patient's age and physical condition. The most common types of treatment include surgery, radiation, chemotherapy, or a combination of these. If the tumor in question can be reached easily, so it's not near a vital structure, and or the surgeon does not need to cut through other brain areas to access it, then brain surgery is a potential option. This surgery, or craniotomy, can be performed while the patient is awake. This is known as an awake craniotomy, or while the patient is anesthetized. An awake craniotomy is preferred if the tumor being removed is in a location that could potentially impact language or motor abilities. If there is no chance that these abilities will be affected, then the patient is typically put under general anesthesia. During an awake craniotomy, the surgeon can directly stimulate areas of the patient's brain tissue to make sure they can be removed without causing functional abnormalities. You might be thinking, wouldn't the patient be in a lot of pain if they were awake during the procedure? Well, The brain doesn't have pain receptors, so the patient would not experience pain at all. Here's how an awake craniotomy works. After using a variety of scanning and imaging techniques to determine the tumor's location, the patient is scheduled for surgery. On the day of the surgery, the patient is given anxiolytic medications to inhibit any anxiety they may be experiencing. The patient is then positioned in a neurosurgical head restraint that holds the head completely still. Next, a general anesthetic is administered until the surgeon is ready to perform the brain stimulation part. Once the patient is put under, the anesthesiologist uses local anesthetics to numb the skin and bone of the head and neck. The surgeon then removes an area of the skull over the tumor and cuts through the meninges, which, as we've already said, refers to the membranes that protect the brain. At this point, the patient is awakened and the neurosurgeon starts to create a cortical map. They use a small electrical stimulation device to stimulate particular brain areas and observe any effects on the patient. As we discussed earlier in the course, every part of your body is represented by an area on the precentral gyrus, also known as primary motor cortex. If the surgeon were to stimulate the area of this gyrus that corresponds to your foot, you would twitch or move your foot. The surgeon would then know that they could not remove that part of your brain because it has a function. You might be thinking, well, don't all areas of the brain have a function? So you wouldn't want to remove any of them? The answer is yes, but a tumor often embeds itself into the cortical tissue. And the only way for the surgeon to know whether that tissue is part of the cortex or part of the tumor is by stimulating it and seeing what effect it has on the patient. If the surgeon stimulates an area and it has no effect on the patient, then it is most likely part of the tumor and can be safely removed without causing any adverse consequences for the patient. Stimulating different areas will result in different behaviors. If a motor region is stimulated, the patient will often twitch or move a limb or their face, as I mentioned earlier. If a sensory area is stimulated, the patient will experience a tingling feeling. And if a speech area is stimulated, the patient may not be able to speak. Once the stimulation is complete and the tumor is safely removed, the skull is reattached and the skin stitched up. If the tumor is in a location that makes surgery a non-viable option, then radiation can be used to destroy the tumor tissue. And in cases where the tumor is cancerous, chemotherapy may be added to the list of options. Maggie underwent brain surgery for her tumor, and she was not awake for it. Given that they were not cutting into the brain tissue itself, remember that her tumor was in the meninges? There were no concerns about disrupting her normal brain functions like language or motor abilities. Her surgery took over 6 hours to complete, which is pretty standard. They were able to remove all of the tumor except for about 4 millimeters. This is because that part was wrapped around a blood vessel and it was too risky to try and remove it. To Maggie's surprise, she also woke up to find 18 staples down the back of her head, an area they hadn't operated on. She has a faint memory of someone in a blue gown on top of her, yelling at her. She thinks that at some point during the surgery, she pulled her head away from the restraint that was keeping it still, causing her scalp to be torn. It takes a long time to recover from brain surgery. You can't expect your life to just automatically be normal once the tumor is removed. Since she had hers, Maggie has experienced a lot of fatigue and something she refers to as fuzzy eyeball. Sometimes things look a bit fuzzy in her left eye. She also says that sometimes her left forehead feels heavy. Interestingly, Maggie also experiences what she calls small islands of memory for the 2 years around the time of her surgery. That is, she remembers pockets of things that happened to her, but many of her memories around this time frame are simply gone. Also, for a period of about 6 months after her surgery, her left eye pointed inward like it was crossed. She actually couldn't use both eyes at the same time. Training the eye with an eye patch over time helped her vision return to normal. Since her surgery, Maggie has also gone through a few medication changes. The first anti-seizure medication doctors put her on caused her to become overly emotional and angry. When the doctors changed her medication, she had a seizure during the transition from the old medication, but soon recovered and had no additional side effects. Maggie has to stay on anti-seizure meds, possibly for life, and has to get a brain scan every few years as the tumor could grow back, although it's unlikely in her case. She also has to make sure she doesn't get too stressed out, as stress and fatigue affect her in a very negative way. This is still true today, 5 years after her tumor was removed. When I asked Maggie and Joe what advice they would give to others who are going through this, they offered the following. 1, if you are experiencing symptoms that are not normal for you, go see your doctor. Don't attribute symptoms to being tired or overworked until you've ruled out a medical diagnosis. 2, ask a lot of questions. Be as informed as you can possibly be. Remember, knowledge is power. 3, don't push yourself. Take the time off you need when you need it. If you go back to work afterward, ease into it slowly. Don't overwhelm yourself like Maggie did. 4, seek out support from family and friends, or even support groups. You need support to get through this. One caregiver is generally not enough. Keep in mind that if you have a seizure related to the tumor, you may be barred from driving for a period of time by state law. 5, remember that caregivers need support too. Joe was terrified from the moment he found Maggie lying on the bedroom floor to months after her surgery. It was traumatizing for him not to know what to expect or how much the tumor or brain surgery would impact the Maggie he knew and loved. By sharing this information, Maggie and Joe hope to help others who are trying to navigate these difficult waters. I hope you now have a better understanding of brain tumors, their symptoms, possible risk factors, and treatment options. Every patient's situation is different, and you need professional and family support to weigh the pluses and minuses of your options before, during, and after treatment. It's a long process with many ups and downs. In the next lecture, we'll examine 3 rare but important disorders: Huntington's disease, amyotrophic lateral sclerosis, which you may know as Lou Gehrig's disease, and Creutzfeldt-Jakob disease. Take care, and I'll see you soon.